Hey everyone, thanks for joining the Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and an ICU physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, the EMS office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do every day, and thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks. Ashley is a young member at Pikesville. She is helping us with the Zoom platform. Ashley is the one who will send out a link later in this training in the chat. Click on the link, enter some information, and get your MIMS CEUs. If you have any questions about your MIMS CEUs, seeing your training record in the MIMS platform, please stay on with us after this training. Ashley and I will be here to answer any questions and make sure that you have your MIMS CEUs. If you have any issue with signing in tonight, please stay after and let us help you resolve that. We will not be able to give CEUs if you're unable to log in. Super excited tonight to have with us Pam Kyne. Pam is a pediatric nurse with extensive experience in pediatric inpatient care, PICU, Pediatric ER, Pediatric Transport, child abuse, and Pediatric Ambulatory Services. She graduated in 1978 with a BSN and in 2010 with an MSN degree from the University of Maryland School of Nursing. She is currently employed at Children's National Hospital as a professional practice specialist and also serves as adjunct faculty and clinical instructor for the University of Maryland Medical Center. She holds several clinical certifications, and she is a dedicated educator. Pam, thank you so much for being with us. We super appreciate you taking the time out to share with our community, especially during the peak of winter season and respiratory distress for our little ones. We thank you.
Thank you. Good evening, everyone, and thank you, Dr. Barinholtz, for that introduction. I consider it a privilege to present tonight and look forward to sharing this time with you. I would first like to say, as a nurse of many years in pediatric EDs and trauma centers, I wanted to say to you in the audience that you have my sincere respect and admiration for all you do in the field to save lives and optimize health outcomes. Working with limited human and material resources, you continue to provide top-notch care for all patients throughout the age spectrum. You do this with expertise, skill, and selflessness, a truly admirable accomplishment, no doubt. So thank you. In tonight's presentation, it is my intent to accomplish the following objectives. They are a bit lofty, but we'll try. We want to discuss the challenges for EMS providers in responding to pediatric respiratory emergencies. We want to analyze the difference between infant and child anatomy, physiology, and assessment as compared, pardon me, to the adult population. We're going to review some common disease, illnesses, and conditions that can lead to respiratory distress and or impending respiratory failure. We're going to describe optimal treatment interventions and management of the pediatric airway and respiratory emergencies, and share some of the tricks of the trade and also work on some case scenarios together. I realize that for many of you, this may be a review, but my hope is that this information, as well as the tricks of the trade, may be useful to you in the field, caring for the most vulnerable of your patients. I am going to do that. Here we go. Over. Okay, so there are many, in looking at some common challenges, we acknowledge there are many that make caring for infants and children daunting. There is a variability in training and practice opportunities for you as providers. There can be infrequent clinical experience and use of your skills. There are often high acuity and high risk situations that arise quickly with children, as they often change on a dime. The anatomy and physiology of infants and children pose many nuances for us. There are often limited pediatric specific care sites for you to transport your patients. Caring for a very sick child is often emotionally charged, and there are parental oversight concerns as well as parental obstructions at times. Patient cooperation and the patient's ability to understand what's going on can also be difficult. There's a big evolution of pediatric home care technology that you may be faced with entering a home. There are developmental and communication considerations through the ages to also be considered. Medications are weight-based, milligram per kilo per dose, not just a simple Bristojet. And there are increasing numbers of surviving premature infants with complex multi-system issues. It seems that we're starting to be able to save children as young as like 22 weeks of gestation. We understand the importance of a thorough respiratory assessment. The number one reason for pediatric cardiac arrest is respiratory failure. One could argue that it is easier to turn around a respiratory distress event rather than a cardiac arrest. So correcting and maintaining oxygenation, ventilation, perfusion are critically important elements of the care for pediatric patients. We realize kids are not miniature adults. Perhaps the biggest difference is how quickly they fall into life-altering situations. With adults, it seems to be a slower transition to get themselves into a life-altering situation, where children, a lot of times, very strong, and they just go, and like little ever-any bunnies, they just go until they fall over. There are many differences to consider. Another major difference is in their airway anatomy. Differences are most pronounced at birth, and the most unfamiliar non-adult-like airway is encountered in neonates and infants under 1 year of age. Some things that we consider when looking at the anatomy is that the head of the pediatric patient is larger relative to their body size, and they have that prominent occiput. The larger occiput combined with that shorter neck makes laryngoscopy more difficult due to the alignment of the trachea. The tongue is larger and the mandible shorter in the young child. The neck is flexed when they lie on a flat surface. Infants under 5 months of age are obligatory nose breathers. And then the prominent adenoids and tonsils are frequently found in preschool age children. The hypopharynx of the pediatric patient is relatively shorter in height and also narrower in width. The larynx is higher in the neck of children, and children are often prone to airway obstruction with sleep. This picture highlights why a small amount of airway edema can be extremely concerning. So you can kind of see what the normal is, and then what happens with, just a little bit of edema versus with the adult. I love this picture because it really sort of pulls it all together. You can see that large occiput, the thin, hollow, underdeveloped mandible, the floppy omega-shaped epiglottis. They have the narrow subglottis, the high larynx, large tongue, and the narrow nares, making it difficult. We uncover more differences regarding the pediatric airway physiology. So the lung volume of infants is disproportionately small in relation to body size in the early postnatal period. The development and growth of lung and surrounding thorax continue during the first year of life. Oxygen consumption is relatively greater than that of the adult. The volume of air remaining in the lungs after a normal passive expiration is lower than that of the adult. The respiratory rate is elevated to achieve the need for higher minute ventilation to eliminate the higher levels of CO2. Infants and young children become rapidly desaturated with hypoventilation or apnea of relatively short duration. And the ability of pediatric patients to maintain adequate oxygenation rapidly declines in response to the physiologic stressors of infection, inflammation, and injury. So, two important points to always keep in mind, again, as we kind of go back and review. Infants and young children become rapidly desaturated with hypoventilation or apnea of relatively short duration. It doesn't take much. And we can see in this little infant the cyanosis of the peripheral cyanosis. The ability of pediatric patients to maintain adequate oxygenation also rapidly declines in response to the physiologic stressors of infection, inflammation, or injury. So the central cyanosis is pretty easy to identify, but pretty significant. There is not a shortage of diseases and illnesses that can lead to respiratory distress and failure, unfortunately. Pediatric diseases, illnesses, and conditions that can lead to respiratory distress and or impending respiratory failure are quite a few. First, let's look at some upper airway causes of respiratory distress regarding your nasopharyngeal area. So a simple upper respiratory infection, common cold, can cause problems. Their noses, the infants are obligatory nose breathers. When that nose is stopped up and they can't breathe through their nose, they can get into significant respiratory distress. Increased secretion production. Children, young children, infants often have a hard time with handling all the extra secretions that can be formed when you have a viral infection. Anaphylaxis obviously is another big issue. Subglottic tracheal stenosis, any foreign bodies. We know that children love to put things in their mouth, as they experiment with things. Cystic fibrosis, croup, epiglottitis. We don't see too much epiglottitis now that we have the H-flu vaccine, but we still do continue to see a fair amount of croup in our younger children. Chronic lung disease is evidenced through how many, more premature children are being saved. Kids with occluded tracheostomies, kids with obstructive sleep apnea, and obviously the airway trauma. And then we have the congenital malformations where we have large tongue, smaller jaw, and larger occiput. When you think of children with Down syndrome, they have a large tongue, the narrow bridge of the nose. All those contribute to some upper airway disturbances or potential for upper airway disturbances. So regardless of the etiology of respiratory distress or failure, using the assessment triangle will help us quickly decide what interventions we need to make and hopefully prevent a respiratory arrest situation. So using your respiratory assessment, you walk into wherever you're walking into to respond to your patient. The first thing is looking at their appearance. Do they have an abnormal cry? Is it very high pitched? Is it stridulous or is it absent? Are they unable to talk? Do they have a decreased response to parents or the stimuli around them? Are they floppy or rigid? Are they floppy, have a rigid muscle tone, or are not moving? Looking next at their work of breathing, is it increased, excessive, nasal flaring, retractions, significant abdominal muscle use? Are they, having regular breathing, decreased breathing? What is their rate? What is their effort? Is their breathing noisy? Are they having head bobbing? So with every expiration, is the head bobbing forward? And then their skin. Is their skin cyanotic, mild, mottling, or paleness or pallor? So obviously, any child presenting with any number of these, we know that we have a true emergency on our hands. When performing a respiratory assessment of an infant or child, consider the following. So, is the stridor that you're hearing, is it inspiratory or expiratory or both? Is it a persistent cough, which we often see with a lot of children with asthma? There's not so much wheezing, but they have the persistent cough. Is their voice hoarse? What is their respiratory rate? Is it increased? And is their heart rate increased for age? what signs and symptoms of increased work breathing are you seeing? Are they drooling? Drooling for infants when they're teething is normal, but it's certainly not a normal finding in, a 2 or 3 year old. How much flaring are they doing? How much nasal congestion do they have? What are the nasal secretions like? Are they irritable? Are they sleepy? Is there a presence of circummoral cyanosis? What is that pulse ox rating? Is it, greater than 93 on room air or not? Are they having periods of intermittent apnea? So we say that when I work with my, nursing students at university, I always say, you want to have that stethoscope on the chest for a full minute with your infants and young toddlers, because they often have irregular respiratory rates. If you're only listening for 15 seconds and you multiply by 4, you might miss a period of apnea, which we define as no breathing for 15 seconds. And, are you finding your patients in a sniffing, or they have their head up like they're sniffing position or a tripod position? So there's so much that we always have to remember, in all the work that we do, but in pediatrics, sometimes I feel like we've got all these different ages and different sizes of equipment and different vital signs. So this is sort of, it's just a ballpark way to sort of remember respiratory rate norms. So kind of easy to breathe. Teens breathe in the teens, and then we go from there. So teens breathe in the teens, school-age children generally breathe in the 20s, toddlers breathe in the 30s, and infants, generally breathe in the 40s for normal respiratory rates. So hopefully that's a quick, easy way for you to kind of remember that. And just, again, kids can be tricksters. So if children have a lot of upper airway, nasal congestion, a lot of times it's helpful to use a bulb suction and try to pull that secretion out of the nose before you listen to breath sounds. If you take yourself and you put your hand on your top clavicle and then put your other hand on the bottom of your rib cage, there's all that room in there for, someone to be able to assess your breath sounds versus, the infant. Sometimes you might only have a couple of inches there. So if there's a lot of nasal congestion, a lot of times those airway sounds can be transmitted down. Again, if you're trying to decide if this is, stride or if it's some other sound, lower airway, putting the bell of your stethoscope on the side of the neck can be helpful. And just, sort of a caveat that infants and children will breathe much faster with the fever. So, if a child has, 103, 104, they're going to be breathing a lot faster. That doesn't necessarily mean they're having any compromise in their respiratory system. It's just due to the fever. There's some, I thought I would pull up sounds of croup. Dr. Barinholtz is going to play that for you so that you can hear a sound of croup.
You ready?
Yes, thank you.
Yeah.
I don't think we're hearing it.
Did you hear that?
Yes.
You want to play
Hopefully.
one more time?
Yes, please. Thank you. Thank you. So that's a very, kind of different sound than we would hear with wheezing or rhonchi or rail. So just, and there's also like a barking cough that children often display when they have croup. So there are a plethora of interventions for upper airway disturbances that you can use. So I have a few here, but one of the tricks of the trade that I found is always helpful is, making sure, especially for these little guys, if you look at the picture at the bottom of the screen there, where we have a towel that we use as a shoulder roll that helps open up that airway so the chin isn't laying on the chest and open that up. Jaw thrusts are also very helpful. Making sure that you have the right size catheter for doing your NP or your oral suctioning. So catheters generally run from size 5, which you would use for your newborns, all the way up to size 14, which you would use for your larger adult, or your larger adolescent. The adjunct of nasopharyngeal or OP airways are always very helpful, especially an NP airway is great for when patients have seizures. Maybe they've gotten some rectal Valium at home and they're struggling a little bit with their airway. Putting in that NP airway will help keep that open for you. Obviously, we know that we would never use an oral pharyngeal airway for anybody who is awake, because that's just going to cause them to gag and they wouldn't let you get it in either. When you're putting in an NP airway, you're going to measure. There's a picture up there on the right. You're going to measure from the lobe of the ear to the opening of the nose. The bevel of that NP, the bevel of the NP airway is going to face the nasal septum. Okay. Again, those come in all different sizes. You can see there's a lot of different sizes of those are in the middle picture there of the oral airways. The NP airways also come in many different sizes. The nice thing also about an NP airway is that you can suction through it, which is, helpful. There are many inhaled medications that can help. For instance, with croup, sometimes in addition to cool air blow by, we can use racemic epi. And then I also like to bring up that guardian support for all these patients, no matter what you're doing, is really important. So I understand it's very different in an ambulance situation where maybe parents aren't allowed to sit in the back or they can't for whatever reason. But when you can have a parent be with the child, hold the child, support the child, that's going to be the best scenario for that child, because they're going to be less irritable, they're going to be crying less, and then that just makes your job so much easier. And, also if they're not doing a lot of crying, it's going to help their respiratory effort. The other thing to be always thinking about is use your least invasive maneuvers first. I took care of a child recently who, after an oral medication, had a laryngospasm, quickly dropped the SATs down in the 50s, was breathing very fast, just was really in distress. And, the initial sort of knee jerk was, oh, we need to intubate. But, we took a minute and just everybody time out here a minute. Let's focus. And, we looked at some other maneuvers, gave a neb, helped put an NP airway in, did some other things that helped so that we avoided intubation on this child. So, always like to say the least invasive maneuver is always your best starting point. Tracheostomy change, unless we're working with tracheostomies every day, that's not something that we always like to do or feel comfortable doing. But if you have a child and that tracheostomy is occluded, it needs to come out and a new one needs to come in. Again, if you are at a family, families are used to changing the trachs. They usually change trachs every, once a week or more. They can assist with that. But, if a trach is occluded, there's no sense trying to work with that. It needs to be changed. If you have a child with a foreign body, if it's an infant, we're going to start with the back blows and the chest thrust. An older child, we will use the Heimlich. If that child becomes, whether the infant or the child becomes unresponsive, then we're going to go right to CPR. So with the child, we can use the heel of one hand. We do not do blind finger sweeps. We look for that object. If we see that object, we can pull it out, but if not, we do not do blind finger sweeps. And then for the infant, you can either use, 2 fingers to do your chest compressions, or the 2 hands encircling. Now the American Heart has updated that ability for us to do that. And the only exception to that with with general CPR is that we're going to look every single time to see if we see the foreign body, if we can pull that out. Obviously, oxygen is a good thing if someone is desatting with an upper airway disturbance. And I always like to say frequent reassessment. kids change so quickly, either for the better or for the worse, but they really do change very quickly. So your frequent reassessment with these kids is paramount in their care. And then obviously the use of IM epi for anaphylaxis. Dr. Barinholtz is taking care of the chat for me, but I just want to stop for a minute. Does anyone have any questions so far or anything that they'd like to add?
I have a question for the community. I think that most of us do transport the parent with the kids. I think we try our hardest to transport. Does everyone agree with that?
Yeah, I agree with that.
Great, thanks.
Yeah, I think it's really important. Parents know their children best, and especially the parent of any child with special needs, they know those children like the back of their hand. And even like in the hospital situation, sometimes as we're in the hospital and we have, we feel like, well, we know our business, we know our service line, but oftentimes parents will say that's not going to work. And I think, it's always best to really listen and hear what they have to say, because they know their kids better than we do. It's been my experience. Thank you.
Yeah. Somebody said yes, unless they're distracting for care. Totally agree with that. And then somebody else said, yeah, they're all belted in appropriately. Completely agree with that too.
Yeah. Okay, so I have just a few case scenarios here. So I think I'll read them out, and then if you guys can participate, and Dr. Barinholtz will let me know what you're saying. But there's the call that's going to come over. It's a 3-year-old, 15-kilo child with trouble breathing, and you hear there could be a possible food allergic reaction to a nut product. And then, your initial impression, so you walk in and you see this child, your initial impression is that they're irritable. They definitely have some inspiratory stridor that you can hear even without a stethoscope across the room. They have moderate retractions that you can see. They are kind of got their head elevated in that sniffing position, sitting on the parent lap. They look a little bit pale, and you see hives on their face, their chest, and their neck. As you get further into the assessment, you see that they are afebrile. They're drooling quite a bit, and they're 3. They do have lip swelling at this point. They have diffuse bilateral wheezing. They have moderate intercostal retractions. Respiratory rate is 50. And remember, we said he's 3 years old. Heart rate 120. Pulse ox is 91 on room air at this point. The systolic blood pressure is 80 over palp. Your capillary fill is 4, and your distal pulses are 30. I assume, please correct me if I'm wrong, that you use sample to get a history. Is that what you're using in the field to get a quick history from families?
Yeah, I think there are a number of different frameworks, but certainly most are familiar with sample.
Yeah, so sample, we're looking here at the signs and symptoms, allergies, if they know any medications that they're on, past medical history, when they had their last meal, and events leading up to the problem. So this kid, we hear, started to cough immediately after eating a cookie, has diffuse hives all over. Mom mentioned seem to be having trouble breathing, a lot of coughing and choking, but the child has no known food allergies that they're aware of. So I'm just wondering, based on kind of what you're hearing here, what is your, what do you think is going on?
Allergic reaction, there's always a first time.
Yeah, definitely going into the allergic reactions. So we're kind of identifying this kid is probably experiencing anaphylaxis. So when we intervene, we can have the child in a supine position. That blood pressure is a little bit low. I have a formula for you that I find very useful. We use it for children less than 10 in trying to quickly figure out what is the normal versus minimal systolic blood pressure for children less than 10. So the blood pressure formula that we use for systolic is, so normal blood pressure would be 90, the number 90 plus age times 2. So this kid is 3, so it would be 90 plus age times 2, 3 times 2 is 6, it would be 96. The minimal systolic blood pressure is 70 plus age times 2. So minimal systolic blood pressure for this kid would be 76. And this kid is sitting at 80. So kind of trending down to the minimal systolic blood pressure for age. So would not hurt to try to, get that child's feet elevated up to try to increase that blood pressure. Definitely provide some oxygen via a non-rebreather. Again, we have 3 sized non-rebreathers for children. We have the infant one, and that usually requires us just to set it on about 6 or 7 liters, to get the bag full. And then if it's a pediatric or the, adult one, obviously 10 to 15 liters we use. We're going to do everything we can to maintain airway alignment. But what this kid really needs is the IM epi. So, the paramount thing, the number one thing that we should be thinking about is the IM epi. So there's sort of your dose. It's 0.01 milligrams per kilo. This kid's 15 kilos. You're using a concentration of 1 milligram per ml. That's going to be 0.15 milligram given IM into the thigh. I actually sat in on one of your presentations earlier when someone did a presentation on anaphylaxis, and I think they're looking at saying, I guess, in older people, rather than just use the thigh, you can use the deltoid. So that's new information. If you think that you're going to need a bolus for this child, you can use 20 mLs per kg. We said he's 15 kg. So does anybody want to tell me how many mLs we're going to deliver this child over a 20-minute period?
$300, somebody says.
300 mLs, perfect. And we're going to try to get that in about 20 minutes. For younger kids, when we're given boluses, we tend to use a push-pull. So we'll use a 60 cc syringe. We'll pull out what we need, hook it up to the IV tubing, and just sort of pull-push. That's a quick way to do it. I know for older people, we'll use a pressure bag, but for these little guys, the danger of a pressure bag is that we would be given too much fluid. Reassess, reassess, reassess. So we can repeat this every 5 minutes. It's not uncommon for children or anybody actually to have a rebound. Are there other actions that you feel like would help this child in the field? What other things do you think might be helpful?
Oxygen, somebody says. Yep, we
Okay.
covered that.
Oxygen, yep. And I think the most,
Benadryl.
pardon me?
Benadryl, somebody says.
Yeah, Benadryl, yeah. Steroids, yeah, there's a lot of other things that go down your protocols. So, and I think for this family, there might be some time on the ride to just begin to talk to them, just lay a little bit of groundwork around family education for children with peanut allergies, because it's a pretty big issue these days. Okay, let's see. So at this time of the year, we're all very familiar with all of these lower airway disturbances. There's asthma, which is, top there, all the respiratory viruses, RSV, it's really rearing its ugly head right now. The adenoviruses, rhinoviruses, coronaviruses, parainfluenza, enterovirus. Then we have the bronchiolitis, the bronchitis, the kids that, will develop spontaneous pneumothorax. We see that a lot in our very lanky adolescent males. And then there's pneumonia, and then of course pertussis. So, there are a fair amount of children, I'm not going to say majority of children, but there are, notable amount of children that are not immunized these days. So we always, want to be thinking, outside the box in terms of, what may be causing some of these airway obstructions. Are you guys, in the last couple of weeks, are you still seeing very high rates of respiratory viruses as a primary call for pediatrics? Excuse me.
Yes, somebody says.
Yeah, it's quite a bit. And those kids, they can, especially these little infants, they can decompensate very, very quickly. In infants with the RSV, they're going to be irritable, they're going to have poor feeding, and they don't get really bad until I guess it's like, I want to say day 3 or day 4 into the illness. That's when it really starts to crescendo. They work up to it. So they're irritable, they have poor feeding, they're lethargic, they do have pauses in breathing, and you don't always have a fever with that. With kids, going to be a runny nose, decreased appetite, cough, sneezing, and fever. And then of course adults can get RSV too. I often heard it described as the worst cold you would ever have when an adult gets RSV. But there's the runny nose, sore throat, cough, headache, and fatigue. So RSV can be pretty dangerous for any of our patients that are immunocompromised, children that have tracheostomies, children with cystic fibrosis, known pulmonary problems, diseases. Right. Okay, so
Somebody said, sorry, I was on mute. Somebody said that they can have lung collapse secondary to RSV as well.
Exactly. That's a very good point. Thank you for that. Many of the respiratory assessment findings are similar to those found in the respiratory assessment findings for lower airway are similar that you're going to find in upper airway disturbances. Auscultating for altered breath sounds take time and patience. So, forget trying to listen to breath sounds if a child is crying. That's just not, it's a waste of your time. So, that's why we feel like, having parents around will really help. For those of you who have children, that there are a lot of ways to try to get, an infant or a toddler to stop crying. I know for infants, holding them close, chest to chest, patting their little bum seems to go a long way. Singing. I do not have a good singing voice at all, but, I can do, Farmer in the Dell, Old MacDonald's Farm, the Happy Birthday song. It's amazing how you singing can really help calm them down. Again, distraction. There's just so many things that you can do to help get cooperation from your pediatric patient. Some of the things that you're going to hear would be the same that you're going to hear in your adults. It just might be harder to hear. So you do want to warm up the bell of your stethoscope. When you put a cold bell of a stethoscope on a child, it's going to startle them and may even start them crying. I know my pediatrician, when I was growing up, he always put the bell of a stethoscope underneath of his belt, and it was always warm. So, you could hear the wheezing, which to me is sort of a high-pitched whistling sound is how I would describe it. Rails. You take your hair and you rub your hair together in front of your ear. That kind of sound to me is what rails sound like. Bronchi, just a real guttural sound. And of course, breath sounds the same. Many of our teens who come in with status asthmaticus, they're running track. This is a big meet that they're at. They start wheezing during the run, or they forgot their albuterol before the run. They're going to finish that run. They're going to finish that meet. And by the time you get involved or they get brought to the ED, a lot of times we can't even hear breath sounds. They're so tight. So you may hear diminished or absent breath sounds. Again, you're going to see retractions. When you see retractions that are suprasternal, when you see retractions that are supraclavicular, we know that the patient is in severe respiratory distress and impending failure. Grunting, we often hear in the younger population. So at the end of each expiration, you're going to hear Head bobbing, we've talked about, and nasal flaring, we've also talked about. Pulse ox, anything less than 92 on a child who doesn't have a congenital, cardiac cyanotic heart lesion is going to be very concerning. Any circumaural cyanosis or color change is important to note. And again, what is their respiratory rate and heart rate? A persistent cough, what is going on? Are they, is this a precursor to their wheezing? Do they have a foreign body? What's going on that's causing the persistent cough? There you go again with your intermittent apnea periods, shortness of breath. And then a lot of kids with asthma, they track their peak flows at home. So, if you have a child with asthma, it's often helpful to say to a parent, have they been checking their peak flow and have they noticed a trend downward in that? And then, of course, anybody unable to talk in sentences, we know that that's a huge red flag. So many interventions for lower airway disturbances, your albuterol administration. Just to note a little bit about albuterol. So there was a study done many, many years ago in Ohio, at one of the children's hospitals, where they looked at the efficacy of using albuterol nebs versus albuterol MDI. And I know as an ER nurse, when we first started using albuterol MDIs, there was a little bit of pushback from parents because parents always felt, they brought their kid to the ED, we gave these magic nebs and they got better. But in reality, what they've really found is if a child does not need oxygen, and if they're able to do the MDI with spacer, there's a lot more medicine that gets, deposited down into the lung tissue where it's needed. So, obviously, if someone needs oxygen, we're going to use the albuterol neb. So I'm just curious, are you doing MDIs in the field, or is it all nebs?
It could be either.
Either. Okay. Also, it's
Do you agree
important.
with that? Those online, do you guys agree with that?
Okay. Also, it's important to note that the early administration of steroids help to begin decrease the inflammation, and then that's going to result again in easier diffusion of the bronchodilator. So getting that steroid on board is going to be very important. Nasal cannula, if you're going to give oxygen. The thing with nasal cannulas is if someone's nose is all congested and stuffed up, nasal cannulas don't work very well. So it's often better to think about a different way to give oxygen rather than a nasal cannula for kids with real stuffy nose. Our max for children is 4 liters via nasal cannula. Non-rebreather, again, setting that up to 10 to 15 liters. If you do have to bag for children, the latest American Heart Association recommendations are 20 to 30 breaths per minute. Sometimes it's helpful too, just to do a little bit of oxygen blow by. So depending on what type of ambu bag you have, if you have an ambu bag that's got the tubing that comes off the back end with 100% oxygen, sometimes children tolerate that better than a face mask. Again, using the least invasive procedure is important. Guardian support, the frequent assessment, and hydration. So kids have a lot of insensible losses when they're breathing above their normal rate, when they have fever, those kinds of things. So, the more hydrated the patient is, the easier it is for them to cough up and get rid of the mucus in their lung. And then, of course, if able to be able to do the end-tidal CO2 monitoring is very helpful. So, pulse ox, letting us know oxygenation versus the end-tidal, more about the ventilation of the patient. Helpful adjuncts there. So here's another little case scenario here. So you get the call, 10-year-old with trouble breathing. When you go to the house or wherever they are and you look, they're agitated and anxious. They have suprasternal retractions, nasal flaring. They're coughing a lot. They're pale. Lips are looking a little cyanotic. They're in the tripod position and their skin is beginning to mottle. Upon closer assessment, you find that they're breathless when talking. They're 10 years old, they're breathing at a rate of 40, their heart rate's coming in at 120. They have moderate intercostal retractions. They have bilateral inspiratory, expiratory wheezing, pulse ox 91, room air, and they're pale. Their history, and you probably hear this quite a bit, known diagnosis of asthma, but they ran out of albuterol a week ago. They've had cold symptoms for 4 days. They've been febrile to 101. They've had 2 PICU admissions in the past 2 years, and parents smoke in the house. So what do you think, what would be your working diagnosis here? And what would be your protocol that you would follow?
They'll chime in. They just need a minute. Asthma.
Okay. All right. And what are your initial interventions? This kid seems like he's in pretty significant distress.
Duo neb, epi, oxygen. Neb, dex, epi, mag.
Would you do MAG in the field?
We do mag.
Gosh, that's incredible. That's great. So that's going to help with the relaxation of the smooth muscle. How about terbutaline? Do you do that in the field as well?
We do have terbutaline. You guys check me. Do we have terbutaline for kids too? 12 years and older, not at that age.
Wow, that's incredible. It's amazing. Honestly, I learn, I always say I like to be able to be in a position to teach because I learned so much in teaching, and it's incredible all the things that you are doing in the field. My hat is really off to you because
they're amazing, without a doubt.
It's a lot. Okay, so you hit everything right on. So there's your albuterol. If this child was able to do the MDI, it would be the better way to do it rather, although we do need oxygen. So either way, there's your dex. Again, the importance of reassess. Consider epi, which you talked about, either IM or sub-Q, and then other and transport. So I think I have a caveat for this, and we already talked about it, was the MDI versus the neb, and we covered that.
And we heard in the chat that most units do not carry the MDIs, they just have nebs. They can help patients if they have their own MDI, but medic units carry nebs.
Okay, sounds good. So there are also, some things that cause respiratory decompensation that don't have an airway origin. So, these are a few. You can have children with pulmonary hypertension. You have those kids with single ventricle, kids with congenital cyanotic heart defects, kids with either myocarditis, myocardopathy. And then you have your disordered breathing situations. So, that can result from metabolic acidosis, head trauma, post-lithical states, toxic ingestions, and many of the over-the-counter home remedies and nutraceuticals. I don't know if you guys are seeing it much, but I know we're seeing it a lot more in ERs where parents are really getting into nutraceuticals. So it's always good to make sure you include that in your history. So I just have a note here about congenital cyanotic heart defects. So it is of note that the administration of high concentration oxygen for children with congenital cyanotic heart disease. So we're talking, tetralogy of flow, single ventricle, double outlet right ventricle, just to name a few, can cause an increase in the pulmonary blood flow, which is going to result in pulmonary overcirculation, which then again results in right heart failure. So we have to be pretty judicious in our use of 100% FiO2 with these kids with congenital cyanotic heart defect. So we had a kid come into the ED. He was a child with tetralogy of flow and, just some type of respiratory incident. I don't exactly remember if it was, virus or pneumonia or whatever, but child came in, was one at home, 0.5 liter nasal cannula, normally would sat, upper 80s. And, when he came to us, he was satting like 79, 80. And so, someone originally had said, well, let's go ahead and, put him on 100%, but then, quickly remembered, okay, we can't do that. So just taking that child up to 0.75 liter nasal cannula made all the difference in the world for that child. So just sort of something to think about. Another one of those little caveat things.
Another example where parents probably have a lot of good information.
Yeah, for sure. So here's one more scenario. So you get a call, you've got a 9-month-old with trouble breathing. Okay. And then, you walk into the home and you see a child who appears pretty lethargic, just kind of laying there. Decreased responsiveness to the environment, looks not well, looks poorly perfused, has shallow respirations, lots of oral secretions, and there's blood noted in ear canals. Okay. So, upon closer look, you see a child where their membranes are cyanotic. Pulse ox is 85 on room air. Respiratory rate 5, heart rate is 70. Cap refills 5 seconds. We've got weak peripheral pulses. EKG shows a sinus brady. Your fontanelle's bulging and your pupils react sluggishly. And this child is hypertensive for age. And, obviously before you get a history, you're going to be doing some immediate interventions. But in the meantime, you get a history. This kid woke up from a nap vomiting. He was very irritable before his nap, mom says. He has a history of a current viral syndrome with fever. And they don't say, they deny any history of head trauma. So what do you think might be going on? As our initial thought was trouble breathing, a respiratory issue, which indeed this child has, but what do you think might be behind it? Something to think about.
Somebody says shaken baby. Do we believe the denial of head trauma, abuse?
Yeah, exactly. You guys are all over this. This is great. So, obviously, this kid is in respiratory failure, impending cardiac arrest. We need to clear that airway, get the suctions out of there. Bag valve mask ventilation with 100% oxygen given 20 to 30 breaths per minute. Definitely maintain that C-spine immobilization. We don't know what happened. We'll be initiating CPR very shortly if that heart rate goes below 60, getting ready to prepare for intubation. One thing I've learned over my years is that whole thing, everything with stripes is not a zebra. So had a couple kids come in. Had one kid that came in, he's an infant, parents were Spanish speaking, came in the height of the GI season for nausea, vomiting, and diarrhea. And this kid came in, wasn't febrile, but was having a lot of vomiting. So the thought was, well, let's, go ahead and put him in the observation unit, observe, the kid overnight, keep him with IV fluids, then in the morning, try some PO fluids and see if we can get him out. Well, the nurse had checked on that child last about 6 o'clock, 6:15 in the morning. Child was, resting comfortably. Parents, like I said, were they were Spanish speaking, didn't speak English. And she gave report in the morning and, the same situation where, okay, we're, been IV fluids all night. The orders are in the morning to, saline lock the IV and, trial PO hydration and hopefully can go home. Well, I happened to be the nurse that was there that morning coming in. And when I went into the room shortly after report to begin my vitals and assessments, I found a child that was very blue, secretions from head to toe, and, generalized tonic-clonic seizure activity. It turns out that this kid had a brain cyst that had ruptured. So, I always, we know what we know, but again, I think children can be tricksters. And again, always kind of thinking through everything isn't, everything with stripes isn't a zebra. Does anybody have any other stories that you'd like to share that are like that, where you thought you had one thing and turned out to be something totally different?
I think one limitation we all face is getting that outcome information, right? So I think sometimes, we're not sure what the outcomes are. Often.
Often, yeah. So here's just some, getting close to the end of the presentation now, but just a few things that, might be helpful. I'm not sure what, you always have on the ambulance, but just some helpful things. So, remember to try to have children in the position of comfort as much as possible. Make sure that their heads are elevated if it's appropriate. Guardian support, we've kind of talked a lot about. Distraction activities, whatever it is, whether you're singing, whether you pull up something on your iPhone. There's a lot of good, I think it's called Indigo Kids. So it's like there's like ocean sounds and jungle sounds, and just putting that on can be a good distractor for a child. They're wondering where they're hearing that cuckoo bird looking all around rather than crying. These things really do work to help get the cooperation that you need from children. You want to make sure you're communicating with them on their level of development. We've got to be really careful about our language. I remember one time in the ED, it was really busy. I needed to put a line in a kid. I guess he was maybe 5 or something. And, I made the mistake of saying, oh, it's just going to be a quick little stick and then we'll be done. Got the IV in, child did very well, was taping the IV, and all of a sudden he started crying like crazy. And I'm like, what's the matter? And he just looked at me and said, where's that stick you're going to put in? And man, I felt horrible. So I think just being, kids are very literal, just being very careful with how we communicate with them. I think the other piece is something's going to hurt or be uncomfortable. Excuse me, we don't want to lie about it. We don't need to tell them it's the, worst pain you'll ever experience, but certainly, to let them know, we're going to be here with you. We're going to give you some numbing medicine. We're going to hold your hand, those kinds of things. So being truthful with a child builds trust going forward. Use a sample for history to get a quick down and dirty history from a family is, I think, great. Remember too, that for infants that are breathing greater than 60, we try not to offer any type of fluid for them. We're concerned that when they're breathing faster than 60, that there's a higher risk of them aspirating and then getting an aspiration pneumonia. Reward and recognize, whatever you have. I don't know if you guys carry stickers or little certificates or whatever. I know it probably sounds like a lot, but sometimes these little things can make a difference. Be mindful of your terminology. One way that I think it really works well for especially your infants, if you have to give like Tylenol, I understand you're giving Tylenol now, although you don't give it less than 3, is that correct? Did I get that right? Or less than 3 months? And when can we administer Tylenol on the?
We'll wait for people to chime in on that one. Somebody said we do carry teddy bears.
Oh, great. That is wonderful.
No one chimed in. I'll look it up.
Okay.
I'll look it
So
up.
if you have to give any oral medications to infants, a lot of times if you just take a simple nipple, let the child put the medicine in the nipple and then, excuse me, let them suck. That's a good way to get it in. You can also administer it drop by drop, very slowly and carefully in the buccal pocket. But I feel like the nipple works better because that way they can suck and swallow on their own accord. The other thing is, whatever we can do to treat pain. So for infants, if you have to put a line in, and it's not like they're in cardiac arrest type of thing, you'd be probably using an IO at that point anyway, but you're putting a line in a child that is 6 months or younger. There's a substance called oral glucose. It's extremely inexpensive. It's 12.5% glucose, and you just put a couple drips on their pacifier or on their tongue, and it it really, I know it sounds crazy, but it works like morphine would work for adults. It totally takes away pain for them for that short period of time. We also have some vibrating devices that you can put above where you're going to do your peripheral stick that helps distract and really helps decrease the sensation of pain. There is Emla cream. I wouldn't recommend Emla cream because it takes about 15 minutes to work. And then in addition to that, it also can shrink the veins. So just, just a few things around pain treatment. With the equipment, obviously making sure that you have everything that you need. One trick that I've seen in adult EDs that didn't have a pediatric mask is if you turn that mask, normally you'd have the little narrow port at the nose, but if you only have an adult mask and you've got a child, if you turn that mask upside down, you can generally get a pretty decent seal with that if that's all you have. If you do ever look into getting spacers to use with MDIs on your ambulances, there are 3 size spacers, one for infant and then pediatric and then adult. You want to make sure you have all your size suction catheters, same with your airways and your airway adjuncts. If you have the nebulizer, there's some fun pediatric masks that make it a little more easy for children to not be afraid of it. We have one at University of Maryland, looks like a dinosaur. They're a lot more willing to let you put a mask on the face if it looks fun. IV catheters, generally for the infants, we'll put in a 24. For the older kids, we'll put in a 22. Obviously, you need a bigger catheter, an 18 or 20, if there's bleeding on an older child. But we try to, stick with the 24 for the infants and the 22s for your toddlers in school age. Pulse ox probes, they do make pediatric ones that are very nice. And tidal CO2 equipment is very handy. And of course, all your blades and handles for all the different ages and sizes of children. I would imagine that you have the height-based tape to use that gives you a quick reference for a child's weight as well as medications and equipment. There are many pediatric vital sign reference cards that I think are handy. Pediatric drug books are great, but there's also a couple apps that you can put on your phone up to date. The website Up to Date is hugely helpful when I'm trying to figure out dosages. There's also a few apps, and you probably already have them, where you just put in the weight in kilos and up will come your medication dose. Couple formulas for endotracheal tube calculation, where you take their age plus 16 divided by 4. I know there are other ones, but for me, that was an easy one to remember. And then again, once you are tubed, you want to see whatever the tube size is, 3 times the tube size at the gum as a rough estimate that you're in good place. And after, you're listening to breath sounds. Your maintenance fluid, looking at a calculation, 4 mLs for the first 10 kilos, 2 mLs for the second 10 kilos, and 1 mLs for the last remaining kilos up to 50 kilos. So there've been a fair amount of children that have been overhydrated when being seen by adult practitioners. So this will help with that. The 4-2-1 rule, and then ml per hour rate. And then there's your bolus calculation. So 10 to 20 mLs per kg, 0.9 normal saline. And anyone that you're concerned about with a cardiac issue, you're going to go with your 10 mLs per kilo, as well as your neonates, and the use of algorithms. So thank you for bearing with me. We're almost done here. Just there we go again with the zebra, but some pediatric care nuances. Just always remember that infants have irregular breathing patterns. When you have a quiet infant or child, that's never a good sign. Pediatric access, getting IV access can be challenging. We generally say after 2 attempts, stop. Let somebody else try. We talked about the infants and children with congenital synovial heart lesions already. And then the infants need to be kept warm. When an infant becomes cold, they're going to become bradycardic, and then we have another problem. So it's important. always remember too that, we're strangers, and what do we teach kids? Stranger danger. So, whatever we can do to overcome that, is a good thing. And we already said everything with stripes is not a zebra. And the other thing too is, kids can have more than one medical concern. A lot of times, oh, okay, they have asthma or they have this, but we're not always thinking about all the other medical concerns that children can have, especially that, we have, children that are surviving these really young premature ages and have so many complications. And remember your PPE. Kids, they don't know to cover their mouth when they cough or sneeze, and we can get pretty sick from them. So I have a couple algorithms that I've developed. Hopefully might be something that can be helpful to you, or if you're teaching new people entering the field. For respiratory distress, there's our distress. So we're going to determine the cause, initiate position of comfort, support the ease of comfort, try the least invasive method, recognize all of your respiratory red flags, enlist the help of the family, support oxygenation, and stay focused, because again, these little guys change so quickly. The other one is for anaphylaxis. Did it a little bit different. I teach like a first responder algorithm. So this is RESPOND, respond or response for anaphylaxis. So I don't need to read that to you. We've talked about it. But sometimes these little algorithms can help, especially, in an emergency situation. So we have another case scenario about a child with RSV, but I'm looking at the time, it's 10 after 8. So I think we will skip that one if that's okay. And then I wanted to know questions that you have, or any experiences or caveats that you want to share with everybody online tonight.
So we have some clarifications in the chat. So Tylenol is not indicated under 3 months.
Okay.
Somebody offered teddy
Thank you.
bears if anyone needed one for their medic unit. So that's very sweet.
Yeah.
Others said that they carry stickers and teddy bears and little stuffed animals. Someone said continuous reassessment, early interventions, talk to parents, don't ignore your spider sense, distractions, particularly for IV access, be forthright and talk to the child and parent.
Great, thank you.
Breslow tape is what we carry. Many medic units in Baltimore County also have a Bernius card. Dr. Bernius is one of the pediatric medical directors for Baltimore County, and she made up like a tip sheet focused on pediatrics that many providers have.
Mhm.
Somebody asked what your thoughts are on vein finders.
Oh, great question. And I have that written down and forgot to bring it up. So whoever said that, thank you so much. So there are very inexpensive things, transilluminators. They're handheld and they work great. There is something called the AccuVein finder, which is very, very expensive, but boy, it is great for finding veins. If you're really in a pinch, for an infant or a young child, if you take a flashlight and put it in the palm of the hand and kind of, if you're trying to get a hand vein, wrap that hand around the light of the flashlight, that will what's the word I'm trying to say? It'll shine through.
Illuminate.
Thank you. Transilluminate, shine through for veins. But yeah, transilluminators are great because they're very inexpensive and they work pretty well. You also, another trick is making sure that that extremity is warm. So if you have warmers, little, individual warmers that you carry, or like even a heel warmer, make sure that, you put that on before you try to get that vein if you have the time, because it really will help. And PALS guidelines are really, if a patient is an extremis, you're going to go right for your IO. You're not even going to bother with your trying to get a catheter in. And with your IO, the place that we normally will go is your 2 cms below your tibial tuberosity. And we know that through the IO, you can push any fluid or medications, or even blood for that matter. So thank you for that. I appreciate that.
God, I'm getting chest pain hearing about an IO in a kid.
Oh, You need the drill. We have the IO drills now. So it's just a little Heckinger drill goes right in. You don't have to do that turning that we used to have to do. So.
Pam, thank you so much. Thank you for the kudos are coming in. Thanks. Great soup, quick soup to nuts. Thank you. Thanks for being with us. We super appreciate you and yeah, taking care of these kids and help
Wow.
support our community.
Thank you. Well, I wanted to, again, thank you guys for your time and all your participation. And I also wanted to let you know, I have some references here. So they're all there for you. Couple pages, sorry about that. And then I also wanted to thank a few people who have provided content reviews, suggestions, and edits to this presentation. So obviously, Dr. Barinholtz has been great with reviewing the content and offering me suggestions. And Cindy Colson is a nurse that I work with at Children's, but she also is a paramedic. Philip Dar, who's a firefighter and EMT, Nicole Fitzpatrick, who is a colleague. She's a nurse, but she also is an EMT. Dr. Galan is an anesthesiologist from Mercy Medical Center, and Bobby Yoon, who is a nurse who is also an EMT. So I really appreciate them and all they've done to, help with the presentation. And thank you. It's been an honor and a privilege, and I really appreciate it. So thank you. If anyone needs to contact me with any questions or you needed any further ideas about things, I can be reached P as in Paul, Kyne, P Kyne at children's with an S, childrensnational.org. And my cell phone is 301-385-5409. And I'd be happy to talk with anybody. If you had any questions or, any ideas.
We're going to go ahead and take your cell phone out of the recording. That's
Okay.
But thank you.
Thank you so much, guys.
We
Have a
appreciate
pleasant
you.
evening and be safe. Thank
Have a
you.
great night.
Bye-bye.
Bye-bye.